Dr. Hatta Tarmizi.
Bismillahirrahmanirrahim. Thank you very much, Dr. Rizin, for the kind introduction. Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone. I would like to thank the Association of Private Practitioners Sabah for inviting me to share with you a session for tonight. Firstly, I must apologize for not be able to come to your studio tonight to have this live session because of the current pandemic situation. And also, I would also like to start off by saying that my specialty is on fertility. And even though the topic of the discussion will be on fertility and antenatal care, I will touch more on fertility care and what does the general practitioner or the private practitioner outside there can do to help couples who are having problems with infertility and when to refer them to the fertility specialist. To start off with, I will probably spend about 30 minutes to 40 minutes to talk to you about fertility. And I would like to mention here that this is my disclaimer. I have no affiliation to any pharma company, and I'm a specialist now at SabahCare Fertility Center and SabahCare Specialist Clinic. This is the outline of my talk, and we also touch on treatment of infertility at the end. Now, what is infertility? Infertility is the inability of the couple to have an offspring after regular unprotected sexual intercourse for 12 months or 1 year. There are many definitions according to whichever country that you come from, like the NICE guideline in the UK, and also like the American Society of Reproductive Medicine, or even the International Committee. All in all, will mention that those who've been trying to have a baby for 12 months or 1 year, regular unprotected sexual intercourse, but fail to achieve pregnancy, it is defined as this couple is having infertility. However, I must stress here that if the patient, especially the woman, is more than 35 years of age, we do not take 1 year as consideration. We take into a much earlier time frame, which is 6 months. So if they've been trying for 6 months but fail to get pregnancy, then they should come and seek the help of the doctor. As we know, and it's an open secret really, that the fertility has been declining in the past few decades. And as we see in this graph, to show that even in developing countries where we thought that infertility is not a problem, you find that the fertility rate has declined. Now, we have actually done a survey in Malaysia to see the fertility knowledge among the Malaysians. And we find that majority of Malaysians still are very ignorant when it comes to issues of fertility. Almost 2/3 of those who are above 40 didn't know that they would have difficulty if they were trying to conceive at that age. More than half of men do not know that if you do not get an erection, you still can be able to get somebody pregnant. And also, men do not know that they may be infertile even though they have sperms. That means semen. Yeah. About 70% also do not know, of couples do not know that they have to wait, or rather they have to try for about 1 year and then seek the help. Most of them thought that probably we can try 2 to 3 years later, then seek for help. So these are the things that, make the patient come late to see the doctor or the fertility specialist when they come to seek treatment for fertility. The causes of infertility, we can broadly divide it into male problem or the female problem, or combination of male and female problem, or in a small subset we call unexplained, whereby usually after testing we find that both male and female have no problems. We can see that in male problem, as a general, we find that if the sperm has problems in the either mortality or morphology, this can cause infertility problem, or disorders in ovulation, or the tubes may be blocked, the fallopian tubes may be blocked, or like I said, unexplained infertility. Okay, the commonest problem in female when it comes to an ovulation or inability to the ovaries to produce eggs is PCOS, or polycystic ovarian syndrome. This actually is a big topic on itself, and maybe one day we can discuss about it more. But those with PCOS usually will have irregular menses or amenorrhea even, and they may have other signs and symptoms of hyperandrogenism. We find that obesity is one of the leading factors nowadays to cause infertility, be it in male or in female. Because obesity in female is associated with an ovulation and also associated with inability of the embryo to implant itself into the uterus. And in male, we find that it does alter the parameters of the sperm, as well as some will complain about erectile dysfunction. Now, what is the role of the general practitioner or the private practitioner when it comes to infertility or infertile couple? It's very important because the initial assessment is actually done by the general practitioner, and it's aimed at evaluating the main causes of infertility. So history taking is very important. You must get a good history and find why that this couple have this problem. And I must stress that both couple, male and female, husband and wife, must come and see you and to get consultation. It cannot be only one party. Unfortunately, most of the time we find that the female or the wife comes alone and the husband is maybe not in the picture. But both must come together and seek medical treatment. Okay? So a good menstrual history, it must be taken, and you must also find other medical conditions that may contribute to inability of the ovary to produce good eggs. For instance, like thyroidism, hypo or hyper, prolactinoma, PCOS, hypothalamic pituitary disease, loss of weight, Cushing disease, premature ovarian failure, or ovarian dysgenesis. So as you know, if a patient have hyperthyroidism or hypothyroidism, these are the symptoms, signs and symptoms that you may find. And also, you must get a good drug history in order to rule out hyperprolactinemia or galactorrhea. And these are the drugs that may affect that prolactin level in the body. And this is a bit of busier slide, but these are the symptoms, symptoms and diagnostic tests for PCOS, polycystic ovarian syndrome. Like I said, they usually have irregular periods. They may have hyperandrogenism, leading to hirsutism, acne, alopecia, irregular ovulation or reduced infertility, and obesity in 30% of PCOS. There may be other purposeful or endocrinology causes, like in this slide, mentioned in this slide, or if the patient is too extremely lost in the weight, anorexia, bulimia, things like that, it can cause also an ovulation and leading to amenorrhea and inability to get pregnant. So both extremes of weight can affect your fertility, either too much obesity or too less anorexia. And there's another condition called a premature ovarian failure. It happens if the patient develops ovarian failure before the age of 38 or 40 in some books, leading to signs and symptoms of menopause in this very early age. Yeah. So these are one of the ways to diagnose it is actually by taking the hormone bloods. Yeah. Then there are other causes of infertility, like I mentioned before. The fallopian tube is very important. The fallopian tube is where fertilization happens between the male sperm and the female egg. So if the tube is damaged for whatever reason, and the commonest cause is due to infection, either from an abdominal operation or history of pelvic inflammatory disease, or more commonly, history of sexual transmitted disease, this may lead to tubal blockages and damage. And endometriosis also can lead to not only tubal damage, can also lead to other organ damage like the ovaries as well as the uterus. So you must get a good history for that. Endometriosis usually are presented with dysmenorrhea, severe dysmenorrhea, or even endometriotic cysts in some patients when you do an ultrasound scan. Initial assessment also involves taking the social history. Smoking has been shown both in female and male to decrease your ability to get pregnant. Yeah? Your fertility decline with smoking, be it first-hand smoking, second-hand smoking, or even tertiary smoking. Yeah. So the wife may not be smoking, but if the husband does smoke, it will affect definitely the DNA composition of the husband's sperm as well as the wife's oocytes. Yeah. Alcohol intake can be taken, but with a limited amount. Do not take more than 10 units per week if you're trying to conceive. And of course, drugs, especially the illicit drugs like shabu or heroin or morphine, all this can cause fertility problem to both male and female. In male, there's a reason why the testis is developed outside the body, is positioned outside the body. It's because you need a temperature lower than 37 degrees Celsius to produce good sperm. So if the patient has testicular hyperthermia, especially like if they go to the sauna too often or they wear tight clothes, this will lead to increase in the temperature of the testis and eventually affect the production of the sperm. Yeah? There are certain other drugs that may affect the male fertility, like listed here. Yeah? That's why it is very important to get a good drug history from the male patient as well, or the husband. And then you also must get a good sexual history. For instance, how often do they have sexual intercourse between the two? I would say the commonest answer usually about 2 to 3 times a week. But don't be shy to ask, because sometimes you may be surprised. Some couples actually may be quite naive or maybe shy in giving this kind of history. But we found some couples, not all, some couples do not actually know how to have a coital sometimes. Yeah? So you must know how to ask this, even though it's maybe a delicate question. Then you go to general examination or examination as a whole. Look for hypothyroidism, PCOS, weight problem, even Cushing's. And pelvic examination, usually it may not be necessary, digital especially, unless you want to do a pap smear, or you can go ahead and do an ultrasound scan of the pelvis to look at the uterus or ovaries. Yeah. Now, when it comes to examination, also please record the blood pressure of the female and the BMI of the female. An investigation is quite simple. Both male and female need to be investigated. At the general practitioner level, the most important is semen analysis, semen fluid analysis. You must get it done before referring to the fertility specialist. Usually, we advise the patient to go to the lab and send off the semen. Now, they can either produce the semen there, the sperm there, or produce it at home. But if they want to produce it at home, you must advise them to send off the sperm within 60 minutes, so within 1 hour before ejaculation, because if it's too late, you may find a lot of dead sperm or immotile sperm. And also, it is advisable that they have at least 3 days of abstinence. That means do not ejaculate, whichever means, for 3 days to keep it in him, and then only to produce the sperm later after that 3 days. And for female is blood tests. We can either do day 2, second day of menses, FSH, follicular stimulating hormone, or luteinizing hormone blood test, or better yet, if you can do the AMH. This is much more accurate in determining the reserve of the ovaries, anti-Mullerian hormone test. Yeah? The good thing about AMH test is that you do not need to take it on day 2 or day 3 or day 4 like FSH and LH. You can take it anytime, and it gives a better picture on the ovarian reserve, yeah, as opposed to FSH, LH. If we find that AMH decreases as the woman increase in age, yeah, like if you look at this graph here, yeah, it decreases as the woman age. If we find it is low at a young age, we can probably say that her reserve has actually declined. There are certain reasons why this happens. For instance, a patient with endometriosis, especially if they have undergone ovarian surgery, we find that the AMH drops. You know? And then also in certain conditions like premature ovarian failure, like I mentioned before. Right? Other blood tests that you may want to do include the prolactin blood test. If you suspect the patient have oligo or amenorrhea, because we want to rule out prolactinoma. And also thyroid function test if you find that the patient shows symptoms and signs of hypo or hyperthyroidism. Additional tests which you may want to take include, if you suspect PCOS especially, including HSBG and other hormonal tests like estradiol or testosterone level. But these are quite optional, right? Okay. Ultrasound of the pelvis is a good test to do, especially if you suspect polycystic ovarian syndrome. But of course, the best scan is through the vagina or transvaginal scan, because we have a better picture of the ovaries as opposed to transabdominal scan. These are other things, like if you suspect that the patient have the genetic problem like Turner syndrome, then you can probably send off the blood test for karyotyping. Yeah, like for instance, like Turner's, they may be short with web neck, you know, increased carrying angle, things you suspect that clinically, you probably can send off the patient to for the blood test, yeah, for karyotyping. Now, sometimes the patient will probably ask you, how do I know that I'm ovulating? As you know that you can test your urine by using the ovulation kit test to see whether the patient is ovulating or not. But I must stress here, this kind of test is only good if the patient's periods are regular. So you must get a good history of the patient's menstrual cycle. A regular period, usually the normal 28 to 30 days, plus minus 5 days. So between 25 to 35 is still okay, yeah? And usually the period comes about 2 to 3 days to 7 days. But if the period is irregular, or she has PCOS or BCT with PCOS, ovulation kit test may not give you a good picture of when is the ovulation. So the better way to determine ovulation is actually doing a transvaginal scan, a serial transvaginal scan on certain days of the cycle to look at the follicle growth. That's the best way, as opposed to the ovulation kit test. As for male, it's quite simple. They just pass the sperm to the lab. It must be sent to the lab because we can't see the spermatozoa, the naked eye. We can only see the semen, right? So we look for certain things like the volume, but more importantly, sperm concentration the motility of the spermatozoa, and also the morphology or the shape of the sperm. This is the three things that we fertility specialists look more at. So the sperm concentration is, WHO has now revised it from 20 million to 15 million per mil. Yeah, it used to be more last time. Used to be 40 million, but WHO has actually brought it down to 15 million back in 2010. Motility is should be 40% motile, or at least forward movement motility, and morphology now, before it used to be 40% normal, now it's acceptable if it's around 4% normal. Now, I did mention about obesity. It does affect fertility. So at the level of the GP, maybe we can advise those with obesity to reduce their weight. And there's no shortcut in reducing weight, as you know. You must have a good regime of both diet and exercise. The patient must have this good regime in order to reduce the weight. And we find that most obese women will have this problem of anovulation. That means the periods may not be regular, and also they also have inability of the oocytes to come out from the ovaries. So please advise your patient, if they are obese and overweight, to reduce their weight. And sometimes by reducing a weight alone, you can increase ovulation, and they can get pregnant on their own without any assistance from the doctor as well, or the doctor at all. Yeah. There are certain medications that can be given to increase ovulation, and as you know, the most common one are clomiphene citrate or clomid, and another one is Femara, but Femara is not widely used among the GPs because it's more of a specialized drug. But clomiphene can be obtained in any GP clinic, and I would advise that give a maximum dose of 6 cycles and not more, because we do not want the patient to develop abnormality to the ovaries later on. Yeah. Ovulation, like I mentioned, also Femara. What are the complications or risks of clomiphene citrate? Very rarely, you may get twin pregnancy, even though it's here about 10%. It's because that if 2 follicles or 2 eggs are produced at the same time and both being fertilized, then you may have twins. Yeah. And also the theoretical risk of ovarian cancer if you given more than 12 times. So that's why it's not advisable to give more than 6 times. If you want to, but I know patients sometimes they do hop from one doctor to the other, you know, and one doctor probably give 3 cycles, another doctor probably 2 cycles, and another give another 4 cycles. By the end of the day, when they reach a fertility specialist, we find that they're already on 15 cycles of clomiphene citrate, and it's not working. So these are the things that the patient needs to know. Eh? Don't go hopping between doctors and taking clomid like chocolate. And this, so when do you refer to the fertility specialist? If you suspect that the patient have male factor fertility, for instance, male factor including azoospermia, where there's no spermatozoa in the sperm, yeah, at all, then you must directly refer them to the fertility specialist and do not wait for 1 year, things like that, right? And also, if the tubes are blocked by evidence of HSG, yeah, then or hypoxia, then that's where you need to refer to the fertility specialist for further treatment, and do not dwell after 1 year and all that. Okay. And if the patient is already on clomiphene for a few cycles and still not pregnant, please refer to the fertility specialist as well at this point of time. If the patient is more than, if the patient is what we call deemed unexplained, that means the tubes are not blocked, regular periods, they have tried clomid, and the sperm analysis results come back normal, but been trying for 1 year, still fail. Yeah, or if they are above 36, been trying for 6 months and still fail to get pregnant, you know, then you must refer them to the fertility specialist as soon as possible. The earlier you refer them to the fertility specialist, the higher the chance that they will get pregnant or success of any treatment would be better. Yeah. So there are certain treatment for fertility. This include intrauterine insemination or IUI, tubal surgery if there's mild tubal disease, especially if there is blockages at the end of the tubes, but not at the proximal part. Yeah? If IVF is the only way that they can get pregnant, for instance, there's a problem with the sperm, either severely low in count, like oligozoospermia, on azoospermia, or the patient has bilateral blocked tubes, this is where IVF and ICSI comes to play. Yeah, so please refer them early for this if they have this kind of problem. So summary for my first thought is that the general practitioner is the first point of contact for couples struggling to conceive. Initial investigation can be done at your level to ensure appropriate management and better referral to the fertility specialist. Okay, and also ovulation can be determined by taking certain blood tests, especially like I mentioned, the AMH blood test, or day 2 to day 5 FSH, and sperm analysis for the husband, and also tubal status by doing an HSG. Please treat obesity accordingly, because it may help ovulation without any medication at all. And please be watchful of those turning up at your clinic at the age more than 36, because they have no much time, to waste before getting and to get the fertility treatment. Yeah? Now, I like to mention a short part on the fertility treatment. Like I mentioned before, IUI is intrauterine insemination. It's a fertility treatment that involves directly inserting the sperm into the woman's uterus when the woman is fertile. So you can increase fertility of the woman by giving clomiphene citrate, but you must monitor the ovulation by doing a transvaginal scan. So when you see that the follicle grows well, and when the follicle ruptures, and then that is where you can do the intrauterine insemination. Intrauterine insemination involves processing the sperm to increase the motility and to get better morphology of the sperm, and then put back into the uterus when she is fertile. But I must stress here that at least one of her tubes should be patent. It's no point doing IUI if you find that the tubes are blocked, because how can the sperm and egg meet if the tubes are blocked, right? So you must make sure that both tubes, or even at least one tube, is patent if you want to do IUI. So like I mentioned before, who needs IUI? Those with unexplained infertility, those with mild endometriosis, in some conditions, those with using donor sperm, with mild male factor infertility. For instance, the sperm count is slightly lower than 15 million, but not too low, like it's more than 5 or 7 million. Kalau terlalu low, like less than 7 or 5, it's better to do IVF. Or those with cervical factor, even though the mucus during ovulation is the best, you find that some people complain about discharge at the vagina, especially during ovulation. That means she is fertile. But sometimes, if it's too thick, the sperm has problem to go through. So that's why you need the IUI, because the sperm can bypass the cervix and reach to the tubes directly. Very rarely there's a condition called sperm allergy, whereby the female vagina or the wife's vagina just have an allergic to the protein content of the husband's sperm, and she may have redness, burning, and swelling sensation at the vagina. It's very rare, but it can happen. So in this kind of condition, IUI is probably indicated. In vitro fertilization, or IVF, is another treatment. It's where we collect the eggs, the mature eggs, retrieve it from the ovary, and when it becomes embryo, we put it back into the uterus. So the process involves stimulating the ovaries to produce as many follicles as possible, all right? But not too much, because if too many pula, you may develop a complication of what we call ovarian hyperstimulation syndrome. So this is where the fertility specialists have to kita pandai juggle between the dosages of the FSH LH hormone, right? So usually, as you can see in this graph, is given the FSH hormones is given to stimulate the ovary for about 10 to 12 days. So when it reach maturity, the follicle reach maturity, this is where we stimulate the ovary to produce out to come out the egg can or rupture basically, and then we do the puncture or ovum pickup, OPU. And once this is how we do the ovum pickup, is where patients under sedation, we basically suck out the eggs from the ovary directly. It goes to the test tube. That's why last time used to be called test tube babies, right? And then the egg after that will be fertilized with the sperm. We can either do IVF. Conventional IVF is where we release the sperm, the processed sperm, and they will try to fertilize that one egg in the petri dish. If you have problem, or the patient has problem with the sperm, especially male infertility problem, this is where ICSI comes to play. It's where we inject directly. ICSI means intracytoplasmic sperm injection, where we inject the sperm directly into the egg, to induce fertilization. So after the egg collection, it will become embryos like this. Overnight, you'll find that the embryos will become fertilized. It shows 2 pronuclear cells, and then it will develop into 4 cells, 2 cells, 4 cells, 8 cells, and early blastocyst and blastocyst at day 5. So after develop at least at 8-cell stage at day 3 or day 5, this is where we transfer back the embryos into the uterus, right? And after that, the patient will have to take progesterone tablets, especially progesterone vaginal gel, for at least 2 weeks. This is to support the luteal phase, so that the embryos will hopefully, it will implant itself into the uterus. And at the end of that 2 weeks, that's where we do the pregnancy test, either by blood test or by urine test. So in a nutshell, that is what IVF is all about. And we also freeze the embryos if we have excess in number, so that, if the patient IVF initially did not turn out to be okay, didn't be pregnant, at least we have excess or backup embryos frozen to be used later on in order for her to get pregnant. Yeah? So this facility is available here as well. Patient may ask you, what is the success of IVF? It all depends on many factors. It depends also, more importantly, it depends on the female factor, especially the age of the female. That's why sometimes IVF may not be recommended if the patient is too old, and too old means above 40, 43 or 42. Because you look at here, the chance of a woman to get a successful IVF, to be pregnant, live birth at the age below 35 is about 30%. And it declines as the woman ages. At 44, almost 1 or 2% sahaja. This is using their own egg and the husband's sperm. This is for them. So that's why it is better to refer them as soon as possible, especially if some of them do get married later in life. Some get married at the age of 40. Do not wait for 1 year, because Dr. Hatta said you have to wait for 1 year and then see the fertility specialist or see the doctor. No, if you just got married at your 40, you just got married yesterday, if you've been trying for the past 1 month, I must stress that you must see the doctor next month if you still can't get pregnant. So patient may ask you, what are the risks of IVF? I must put there, number 1 is physical and emotional demanding. It is, because it involves a lot of injections, involves a lot of scans. not only financially, you'll be drained out. So you also be emotionally drained, because not all IVF, they must understand, patient must understand that not IVF is successful. If you can see the figures just now, only about 30% are successful at the age of under 35. That means that 70% of those who may not be successful. So they must understand this. That's why good counseling is very, very important. And we do this counseling to all our patients. That's why we spend a lot of time with the patient. Some may get side effects from the medication, especially the FSH LH injections, but it's very uncommon. Another side effect, we call it a side effect, is multiple birth. They may develop twins or more than that. Patients somehow like it, but actually we are not a factory of developing twins, because twins does produce other problems. You may ask the obstetrician, memang banyak masalah. So that's why we don't say that it's a good thing. We have multiple births. Ectopic pregnancy, even though it's rare, can happen. You may ask me why you can develop ectopic pregnancy even though you put the embryo back into the uterus. Well, some embryos, they cannot just sit down there in the uterus. They find their way into the tubes. Somehow they got stuck in the tubes and they lead to ectopic pregnancy. And lastly, this is the most detrimental kind of risk, which is called ovarian hyperstimulation syndrome, whereby if you have too many follicles produced from the injections that the patient take, they may develop ascites, hydrothorax, even pleural effusion, and and this will lead to difficulty in breathing, DVT, shutdown of the major organs, especially the kidneys, and could be life-threatening and may end up in ICU. So this is where the fertility specialists have to really juggle between the doses and to monitor the patient well to prevent ovarian hyperstimulation syndrome from happening. Alhamdulillah, we don't see many of this anymore. So like I said, miscarriages also can happen, especially if the woman is aging or of the older age. And it's mainly due to the aneuploidy effect, because the quality of the sperm, of the egg, is usually not as good as what used to be when you are a younger age. So this is why sometimes they do develop this kind of problem, especially miscarriage. There's another service that we provide as well, which the patient may be aware of, which was called PGD last time, or PGS. Now it's called PGT. It means pre-implantation genetic therapy or testing, pre-implantation genetic testing, whereby we test the embryos of the chromosomal abnormality of the embryos before putting it back into the uterus. This is where we can actually determine the embryo whether it is aneuploidy or euploidy. Even there are two types of PGT, either the PGT-A for testing abnormality or PGT-M, studying for morphology. PGT-M is usually done for those with thalassemia, for instance, monogenic disorders or X-linked diseases. But more commonly, the patient will probably ask for PGT-A, especially those with advanced maternal age, because you know that the miscarriages is higher because of aneuploidy. Repeated implantation failure, been doing IVF many cycles, but somehow the embryos cannot implant or just don't want to implant into the uterus. PGT-A is indicated, because with PGT-A, we only put back the normal embryos. Patients with having repeated miscarriages, severe male factors, and those with a good prognosis. So this is my last slide. I would like to stress again, the GPs, the private practitioners, are actually the frontliners when it comes to couples who are having problem getting pregnant. So you can advise the patient accordingly and how to improve the chance of getting pregnant. And if all measures do not work, this is where you refer the patient to the fertility specialist for other treatments like IVF. All right, thank you very much.
For that very informative talk. Dr. Hatta now will address the question posted in the YouTube platform. Dr. Hatta, I've sent you the link of the YouTube channel so you can access our question as well.
Okay, let me check.
The first question is from Dr. Saijan Samit. Any supplement to increase sperm count?
The question is, sorry, I can't access the YouTube. Supplement to increase sperm count. There are many studies to show that certain supplements may help to increase sperm count, but most of the studies are not very robust studies. There are certain supplements which increase sperm count. For instance, those antioxidants like vitamin C, vitamin E, vitamin D, and CoQ-enzyme 10. Okay, when it comes to sperm motility, there are studies to show that zinc does help increasing the motility. Tapi kan, you must make sure that the patient doesn't smoke. You see, no point of giving them supplements and they are still smoking, because there are many studies to show that smoking itself is detrimental to sperm count, sperm morphology, as well as sperm motility. So make sure that this patient, they do not smoke or even mix around with people who are smokers. Then probably they can benefit from certain supplements. But I must also stress that if you your sperm count is very, very low, severe oligozoospermia, less than 5 million, or even azoospermia, unfortunately, no supplements can help to bring the sperm count from 0 to 15 million or even 5 to 15 million. That one you have to find seek treatment from the fertility specialist. But if your count is around 11, 12, 13 million, those supplements which I mentioned before may bring the count back to 15 million or even 16 million. Tapi there are other factors that we have to consider as well. You may increase your count, you may increase your motility, but so far there is no special supplement to improve morphology. Yeah? Improve morphology. So yeah, you have to find a treatment from the fertility specialist to see whether you can improve your count with this kind of supplement. I'm sorry, I forgot. There's another study to show that selenium does help in improving the sperm count. Selenium. So there's a lot in the market out there, you know, which the patient can buy from the pharmacy.
Thank you. Next question is, I think this is expected already. Dr. Saijan Samit asked about the estimated cost of IUI and IVF, and probably it's also good to explain all the other methods as well. Probably just the ballpark.
Okay. IUI actually IUI depends on the center. Usually in private centers it can range between 1,500 to 2,500. It all depends on the types of medication used, whether FSH injection is being used or not, you know, and stimulation of the ovaries, and usually, so it does range between that. I think you can go to any of the fertility center websites and look for their pricing. For IVF, on the average, it ranges between 15, I would say about 15 to 18,000. Okay, but when it comes to fertility and free frozen embryo transfer, probably it's cheaper than that, usually about 4 to 5,000. So that is the range lah. But you can actually go to their website and see their packages. Sometimes they have these packages, you know, they can offer a better pricing for the patient. Because the thing about IVF is it must be tailored to the patient specifically. That's why we can't give an actual figure, because certain patients may end up with extra or added medication. So that's why there's a range. We can't give as specifically how much, but sometimes it's cheaper than what is produced. But it depends on the patient's punya response to the medication.
Thank you, Dr. Hatta. The next question is from Dr. Wan. Does testosterone supplement helps in male infertility?
Oh, okay. No. Testicular supplement. I understand a lot of our general practitioner colleague tend to give this. The thing about giving testosterone supplement is that it causes you see, you give exogenous testosterone, it decreases the endogenous testosterone. Yeah, it increases the FSH. So what it does is it decreases when it increases the endogenous testosterone, it will and LH hormone, it will cause production of the sperm to be decreased. It is good for those with hypotestosteronism. For instance, you have erectile dysfunction or low libido lah. Tapi it's not good for fertility because the testosterone will definitely affect the production of the spermatozoa. So please don't give. Another question maybe, is clomid beneficial for male? And the answer is no. So clomid is actually for the ladies. So it's not for me. It's like giving a bra to the guys. No point. Doesn't use it.
All right, Dr. Hatta. There are no other questions at the moment, but
Okay.
I would like to highlight the issue that I've talked with you previously on our WhatsApp chat about surrogate mother. Yeah. Do you provide that service here in Sabah specifically?
Surrogacy is meaning ibu tumpang lah in Malay. That means the lady provide her uterus for another couple, sewa basically, or tumpang the uterus to bear that child of the couple's child into her uterus, and then when the child born, the lady then pass the child back to the couple using the couple's sperm as well as egg. For instance, that lady, the couple, the wife tu, dia tidak ada uterus for whatever reason, had an operation done, remove the uterus or cancer of the uterus, so use somebody else's uterus. So that service is actually not available in Malaysia. You go to any centers in Malaysia, they will not offer that service because even though there's no law in Malaysia as yet on reproductive, but the government is developing it actually as we speak. Tetapi it involves a lot of ethical as well as legal consideration, when it comes to that. Because legally, a mother is the person who deliver a baby. So kalau that person delivered that baby, the mother is actually the lady, not the genetic lady yang gave the sperm and the egg. So that's among other things lah. And then what if she doesn't want to give the baby up? Then that's another problem. And then what if do you want to consider that as an adoption ke apa? It's another thing you have to ask. So because of that problem, we don't advocate surrogacy lah. But there are some certain countries in the world who does that. Very popular, India, that's one of it. And I was told Myanmar, Cambodia also does it, legally or illegally, because there's no law also there. Tapi adalah orang buat.
I see. Thank you. So it's not allowed yet in Malaysia. I mean, the service is not yet available.
Yeah.
All right. Next question just came in. No, actually, that's not a question. Just thanking you, Dr. Hatta, for the very nice and informative talk. All right. Thank you very much again, Dr. Hatta. Before we closing the live streaming, probably you want to say a few words, last few words before we say goodbye to all the participants. We have about 37 at the moment watching us at the moment.
Thank you. I would like to thank again the Association of Private Practitioners Sabah for inviting me to give the talk. Hopefully next time we can expand the talk like more antenatal like what is supposed initially as the plan was. Tapi I know as infertility in itself also is quite a big topic. So I hope is the topic will be the talk will be beneficial to all our practitioners, private practitioners, our doctors, and again, I always say this to our colleague as well as the patient. Jangan tunggu lama-lama. If you've been trying for 1 year or even lesser than that and still having problem to get pregnant, please refer the patient to the fertility specialist as soon as you can. With that, I thank you very much. Assalamualaikum.
Thank you very much again, Dr. Hatta, and to all the participants. Now we'll be showing the QR code for the MMA CPD point. Please scan them using the MMA apps. Don't scan them with the MySejahtera. Some people actually accidentally forgotten.
Serious?
That. Okay. Very simple. And I also would like to thank you to my IT person here, Mr. Adrian, who has been very helpful, and also to Ms. Melissa for organizing this live streaming. For those people who have problem scanning the QR code, please register your name at the link given earlier in the WhatsApp group. Thank you again, Dr. Hatta.